Greetings. Thank you for joining us. My name is Eric Middlebrooks, and I'm representing the University of Florida Department of Radiology from the Division of Neuroradiology, and I will be discussing the current and future roles of imaging in neonatal hypoxic ischemic encephalopathy. We will first discuss the current use of MRI in HIE, including a review of the literature combined with some institutional experience. Then we will briefly discuss the literature evidence on the effects of hypothermia with respects to MRI. We will briefly review the role of diffusion tensor imaging in HIE, but I want to focus more time on the potential implications of functional MRI. Lastly, we will discuss the future direction of MRI and the role in HIE. Currently, our diagnostic methods are focused on T1 and T2 weighted sequences, diffusion-weighted imaging, susceptibility-weighted imaging, and MR spectroscopy. Many institutions, including our own, will also use FLAIR sequences. However, these tend to not be as useful in neonates given the high degree of water content and lack of extensive myelination. With these conventional sequences, the findings are often highly variable and depend on multiple factors such as the area involved, the severity of the injury, the gestational age, and the length of time after the initial injury. The cases are usually easy when they're markedly normal or abnormal. Unfortunately, most of these fall into a gray zone and become quite difficult to interpret. We can make some generalizations about the pattern of injury based primarily on severity and gestational age. I've tried to break up the underlying pathophysiology into a succinct summary that may help better understand the processes underlying HIE. We can start by thinking about injury in two general categories, the mild to moderate hypoxia and the severe hypoxia. These two states affect what we know about the underlying hemodynamics and will help us understand the patterns of injury. In the mild to moderate hypoxic states, blood flow is shifted to the posterior circulation to support more vital structures of the brain, including the brainstem. This blood flow shift results in preferential damage to the white matter while preserving more metabolically demanding areas such as the deep gray nuclei and brainstem. In severe hypoxia, this shift of blood flow is still unable to compensate for the profound underperfusion. So in this case, the areas most at risk are those that are most metabolically demanding, including the brainstem and deep gray nuclei, amongst others. In the severe hypoxic setting, therefore, the structures most likely damaged first are the deep gray structures, with white matter damage only coming secondarily, since there's an equivalent hypoxia throughout the brain. So now that we've established this principle, we can predict the differences between preterm and term infants. The differences between these preterm and term groups are largely influenced by the vascular supply, which differs in early preterm infants from the term infants. In the preterm infants, we see white matter perfusion primarily feeding in from cortical vessels, making the periventricular white matter the watershed distribution, and therefore the most commonly injured area, with the sequela being the so-called periventricular leukomalacia. In the term infant, there has been development of arterial input from the ependymal region, which shifts the watershed from the periventricular white matter into the more intravascular watershed zones in the parasagittal locations similar to adults. Therefore, while the propensity for white matter damage is the same in mild to moderate hypoxic states, the distribution differs in the preterm and term infants, primarily because of the shifting of the vascular supply with increasing gestational age. In severe injury, again, the most at-risk areas are those that are most metabolically demanding. There's not quite as drastic of a difference between the areas involved in preterm and term infants in the severe hypoxic case. The thalami and posterior putamen are more commonly seen, while areas such as the hippocampi, cerebellum, and brainstem are typically only seen in profound cases. Now I'd like to briefly discuss the common imaging sequences used and the expected findings in HIE, as well as the expected time course of these changes. T2 weighted imaging is most useful evaluating for underlying white matter disease. These changes usually become evident around 24 hours at the earliest and manifest as increased signal within the white matter with blurring of the gray-white junction. Here are some examples of an HIE patient on the left compared with a normal patient on the right. You can appreciate the increase in white matter signal, particularly in the frontal lobes in the HIE patient. In multiple areas, you can also see blurring of the gray-white junction compared to the normal patient on the right, noticeably here and here. Here's a second example in which the injury is more severe, and we can therefore appreciate the difference between the gray-white junction on the right side versus the gray-white junction on the left side. And when compared to the normal infant, you can appreciate the indistinctness of the gray-white junction. T1 weighted imaging is most useful for identifying gray matter injury, particularly the deep gray structures. The typical findings are increased T1 signal within the gray matter structures related to calcium shift. These findings usually peak a little later and are most commonly seen after 2 to 3 days. Here's an example of an HIE patient on the left versus a normal patient on the right. These findings are often very subtle, as in this case. In the normal case, we can identify the posterior limb of the internal capsule, which usually shows relatively increased signal relative to the adjacent gray nuclei. It's not abnormal to see some increased signal within the anterolateral thalamus, which is seen here, as well as the mesioglobus pallidus here. However, the putamen is typically slightly lower in signal. When we compare with the HIE patient on the left, we can appreciate, particularly in the posterior putamen, that there's increased T1 signal where it nearly blends with the globus pallidus. Another helpful finding, which in our experience is not always present, is a dark appearance of the posterior limb of the internal capsule. But it's also important to remember that this can also be seen in more premature infants, as these tracts are less likely to be myelinated. For readers who do not see a large volume of these patients, it can be very difficult to appreciate the subtle change between normal and slightly abnormal. I find a good internal control is the unmyelinated cortex. The density of the putamen in the normal patient is relatively similar to that of the cortex. When you look at the HIE patient, you can see that the posterior putamen is significantly brighter than the adjacent cortex. One thing to note is something not commonly discussed in the literature is that the use of 3D volumetric acquisitions such as MP-RAGE. This distinction may be a little bit more difficult to make relative to the standard T1 weighted gradient sequences. If you rely on these sequences, it's a good idea to have your own internal control in your mind of what is normal basal ganglia signal versus increased signal. Diffusion imaging plays a major role in the diagnosis of HIE. Essentially, what we are measuring is the ease at which water molecules diffuse in space. The more restricted the diffusion of water implies that there are barriers to normal Brownian motion of water. In the setting of acute ischemia, there's a breakdown of the membrane ion pumps, which results in an increase in intracellular water. As more water is now confined by the cell membrane, we see the resulting reduced diffusivity on diffusion-weighted imaging. This manifests as increased signal on the diffusion-weighted images with a corresponding decrease in signal on the apparent diffusion coefficient maps. The ADC may be more helpful in the neonatal brain due to the inherent high T2 signal of the neonate. Diffusion imaging is typically abnormal between 1 and 5 days. It's very important to note that diffusion may be falsely negative within 24 hours, and it may pseudo-normalize beginning at about 5 days. Later, we will discuss the optimal imaging time for neonates with suspected HIE, and this will be one of the important points to remember. If your imaging protocol includes neonates scanned within the first 24 hours or after 5 days, diffusion imaging may not be entirely accurate in predicting injury and should not be used as a sole predictor. Here are the findings that we typically see on diffusion-weighted imaging, and you can see profound increased signal within the frontal and temporal lobes on the diffusion-weighted imaging with a corresponding decrease in signal on the apparent diffusion coefficient map. Spectroscopy imaging is very commonly used in the diagnosis of HIE. What we are measuring is the proton spectrum for the chemical composition of the selected brain regions. If you remember back to your organic chemistry days, this is essentially the same process used in nuclear magnetic resonance spectroscopy. What we are primarily interested in is the presence of a lactate peak, which occurs as a doublet at approximately 1.3 ppm, or a decrease in NAA, which is a neuronal cell marker. It's important to remember that the lactate peak can either be a doublet above the baseline when a short time to echo is used, or an inverted peak below the baseline when an intermediate or long time to echo is used. We find that the intermediate time to echo resulting in an inverted peak to be ideal because we will commonly see a lipid peak occurring from 0.9 to 1.3 ppm, which may be confused for a lactate peak. This lipid peak does not invert at standard echo times, therefore it's not to be confused with the inverted lactate peak. Spectroscopy may be more sensitive to the severity of HIE than diffusion-weighted imaging and more conventional sequences such as T1 and T2, particularly in the first 24 hours. According to the literature, a lactate peak can be detected as early as 4 to 8 hours, but remains relatively low until the onset of secondary energy failure, which occurs around 24 hours. The lactate levels will peak at 1 to 3 days after injury, then slowly start to decline. The NAA levels typically remain in the normal range until about 3 days. This may not be true in profound injury, but generally holds true in more subtle cases. A decreased NAA is most prognostically accurate in distinguishing normal and mildly injured neonates from severely injured neonates. However, it's difficult to truly quantify NAA concentration. A more easily applicable model is that a detectable lactate peak in the first few days is suggestive of a significant brain injury and predictor of subsequent neurologic impairment, i.e. higher lactate equals worse prognosis. Here's an example of spectroscopy imaging. The graph on the left is from an HIE patient, and we see here that there is an inverted doublet peak occurring at 1.3 ppm, representing lactate, which is severely elevated in this patient who had profound HIE. We also see a relative decrease in NAA. The normal is shown on the right. In this case, you can appreciate that there's an absence of a lactate doublet and the normal relationship of creatine, choline, and NAA. There are some important caveats to remember with spectroscopy imaging. Firstly, we must be certain our voxels do not overlap with CSF, as lactate can normally be present in the CSF of a neonate. Lactate can also be normal in immature white matter. With NAA, the quantity varies with maturation, which is likely difficult to quantify when truly abnormal or normal cases exist. So in summary, these caveats make spectroscopy a little more difficult than the literature would suggest. In our experience, we found that it is often not helpful and frequently does not fit the overall picture that's evident on structural imaging and clinically evident. This may be related to the timing of the study. As we were to talk about imaging timing, this will be another important thing to consider when you decide at which point after injury you'll be imaging these patients. So here I've summarized the imaging findings that we've just talked about. The T1 weighted sequences are good at evaluating gray matter injuries seen as hyperintensity from calcium shift. These findings typically appear at 2 to 3 days. The T2 weighted sequences ideally show white matter hyperintensity and blurring of the great white junction in the setting of underlying white matter injury. These findings are usually present beginning at approximately 24 hours. The diffusion weighted imaging shows increased signal on the diffusion maps with corresponding decreased signal on the ADC maps. These findings may be falsely negative within 24 hours and may normalize after 5 days, resulting in an ideal imaging time from 1 to 5 days. Spectroscopy is used to help identify a lactate peak, which in theory is present almost immediately, peaks at 1 to 3 days, and then will begin to normalize. You may also see decreasing NAA after 3 days in the setting of severe injury. As you recall, spectroscopy is generally most helpful in identifying severe versus non-severe injury in the first 24 hours. Beyond this, it is often not as helpful because more reliable findings become apparent on the other imaging sequences. So this is a patient who was imaged several times over the first 2 weeks of life, and it illustrates the typical evolution of the imaging findings in HIE. On the T1 weighted images, we can appreciate on day 1 that imaging is relatively normal. By day 4, you can now see increased signal within the putamen, which again can be contrasted with that of the adjacent cortex, and you can tell that this is higher than the overlying cortex. By day 12, the imaging findings are relatively similar. There was a hemorrhage in the left frontal lobe. On TT weighted imaging, we can start to see some abnormality by day 1, particularly in the frontal lobes. The white matter signal is slightly increased with some blurring of the gray-white junction. By day 4, this is more evident with near effacement of the gray-white junction in multiple areas of the frontal lobes. By day 12, the findings have started to progress to that of white matter volume loss and leukomalacia. So here is an important example of the role of diffusion-weighted imaging. On day 1, we see no apparent abnormality in this infant with severe HIE. By day 4, you can appreciate now that the majority of the brain is abnormal, particularly the frontal lobes. At day 12, there's been normalization of these areas, some minimal cortical restricted diffusion, and restriction within the corpus callosum is related to underlying seizures. So spectroscopy imaging does reveal that on day 1 there is a small lactate peak, but otherwise normal. By day 4, the lactate peak has resolved, and we can easily see that this lipid peak here could be confused for lactate if you were using a short echo time and were expecting a positive lactate peak. Day 12 was not included as it had a similar normal appearance. So now I'll briefly discuss what we know about the effects of hypothermia on MRI. Unfortunately, there's little longitudinal data to help assess the optimal imaging time, but we can extract some information from a combination of other studies to help us decide a potential optimal imaging time. So when should we be imaging? Well, if there's no intervention planned and the presence of an acute injury will not alter the management, the damage is likely to be best characterized and quantified at 3 to 4 days post-injury. While you may detect the presence of underlying HIE earlier, the scans within 48 hours often underestimate the amount of injury. Based on these points, we would recommend imaging ideally be performed at 3 to 4 days if the characterization of the extent of injury is the desired goal. When we apply interventions such as hypothermia, the effects with regards to MRI are not as well known, and we really have little longitudinal analysis to suggest an optimal imaging time. The best longitudinal data available comes from a low-powered study by Wintermark, where neonates undergoing hypothermia were scanned at multiple time points, including days of life 1, 2 to 3, 8 to 13, and at 1 month. When compared to the later studies, there was no significant difference from the scans obtained at 2 to 3 days of life in predicting the degree of damage. There were also no additional areas of injury seen as far as 1 month out when compared with the 2 to 3 day scan, and the injuries were not significantly underestimated. Essentially, what they found was that patients who had induced hypothermia developed the same sequential MRI changes as a non-treated infant with respect to the evolution of the imaging findings. As with non-cooled neonates, diffusion changes were often subtle if present in the first 24 hours, but were more apparent at day of life 2 to 3. They also found spectroscopy showed an elevation of lactate in injured areas within the first 24 hours, as typically seen in non-cooled infants. The overall results of this study suggest that hypothermia does not appear to alter the evolution of the findings by MRI and is very accurate as early as 2 to 3 days of life. Again, this is a very low-powered study, but it's the best longitudinal data that we currently have. We can somewhat corroborate this data by analyzing other studies that evaluated MRI of infants undergoing hypothermia therapy. While the studies have no longitudinal follow-up at this point to show the evolution, they did show that there were no evidence to support that the prognostic utility of MRI was altered by hypothermia. The studies were mostly analyses of larger trials on hypothermia where the imaging components were extracted. The studies are therefore much higher powered, but not quite as complete as the Wintermark study. A few studies are listed here showing 60-something patients in these trials where MRI was obtained anywhere from 3 to 11 days across all studies. One of the things that appears consistent across studies is the abnormalities involving the posterior limb of the internal capsule and the basal ganglia and thalamus on conventional and diffusion imaging were independent predictors of death and major disability at 2 years of age. Again, this data is from hypothermia patients and cannot necessarily be extrapolated to non-cooled infants. One of the studies I would like to specifically mention is the study by Rutherford, which was composed of imaging data from the TOBY trial. One of the things that they found was that there seemed to be fewer lesions and improved outcomes in cooled infants versus the non-cooled controls. While their scan data consisted of imaging anywhere from 6 to 11 days, a sub-analysis of the data shows that infants scanned at less than 8 days were more likely to have major MRI abnormalities. The reason I bring this to attention is because it's unclear if this is just a selection bias and that scans were obtained earlier in infants with more severe encephalopathy, or perhaps some abnormalities present earlier in the time course may resolve if they had been scanned later. Unfortunately, further scans were not obtained, so we cannot know for sure. Again, this is just playing the devil's advocate of the data found by Wintermark. This can hopefully be resolved in future longitudinal studies. So now I'll briefly discuss the role of diffusion tensor imaging in HIE. This remains a research endeavor and at this point is difficult to implement clinically. DTI has also been studied quite a bit more than functional MRI in this patient population, so I'll only briefly mention it so that we may devote more time to discussing the potential applications of functional MRI. DTI is essentially a variant of the typical diffusion-weighted imaging we're used to seeing. The difference is that multiple diffusion directions are obtained, and that data is used to determine the preferential direction of water movement within a voxel. The processing methods are complex and highly variable, but we can obtain several measurements based on this data. The most commonly evaluated is the fractional anisotropy, which is essentially an eigenvalue for how strongly preferential water movement is within a voxel. In theory, this is an indirect measurement of axonal integrity and myelination. Unfortunately, there are many confounding variables which we will not discuss here. Using these small vectors of preferential water movement, we can essentially connect the dots and perform streamlined tractography as well. Regarding the role of DTI and HIE, there have been several studies reporting abnormal values in multiple areas, including the corpus callosum, posterior limb of the internal capsule, corticospinal tract, and posterior putamen, among others. As we will talk about with functional MRI, the analysis is highly dependent on the methods used both to acquire and to analyze the data. Two primary ways of analyzing the data are used, which employ either whole brain approaches versus seed-based approaches, in which a priori assumptions are made about the areas which may be involved, and these regions are specifically interrogated. So DTI likely plays an important role in diagnosis and potentially with prognosis. Like other methods, there's a large variance of what is truly normal in the neonatal time frame, and these findings fairly rapidly evolved over the first few weeks of life. As mentioned, the analysis is also highly dependent and variable based on both the acquisition and the post-processing methodologies. Even with close standardization, there can be quite a bit of variance from individual machine to machine. Standardization is a hot area of research, and hopefully within the coming years we will see better standard equivalence across machines and across vendors, but this is very difficult to achieve. The last point I want to make with DTI is something that we will revisit shortly with functional MRI, and that is that structural connectivity does not equal functional connectivity. And what I mean by this is that identifying anatomic connections between two areas does not necessarily imply there's a functional connectivity between those areas. This becomes particularly true in neonates and young children, which we will discuss when we talk about functional MRI. So now I want to spend a fair amount of time on the potential applications of functional MRI in the neonate. First, I would like to briefly go through what exactly functional MRI is and how it is potentially applicable in neonates. Blood flow and oxygen consumption are very different throughout the brain. Just evaluating cortex to white matter, there is nearly 4 times as much energy expenditure and flow within the cortex. Further differences are seen just within the gray matter of different anatomic regions. As it turns out, these factors are well matched, which results in a relatively similar oxygen extraction fraction throughout the brain in the normal state. When neuronal activation increases, there's a hemodynamic response initiated which alters the local concentration of oxygenated blood. We refer to this phenomenon as neurovascular coupling, which is just a term describing the expected alteration in blood flow at the onset of neuronal activity. These minor changes in blood oxygenation can be directly measured by MRI. This principle forms the foundation of functional MRI. Classically, functional MRI was largely used with task-based or stimulus-driven paradigms to detect changes in neuronal activity. For example, moving one's finger should produce activation in the corresponding motor cortex and associated sensory-motor integration areas. Currently, there's an increasing interest in what is known as resting state functional MRI. As is well known, the brain uses a tremendous amount of blood flow and energy at baseline. While it was long thought that there was little neuronal activity while a person was at rest, it turns out there is a tremendous amount of activity, which likely explains the etiology of this high energy expenditure of the brain at baseline. We can detect this activity by searching for spontaneous changes in blood oxygenation signal, which are distinct with each other as a patient lies quietly in the MRI when no stimulus or task presented. On this slide, I'm showing what neuronal activity at rest actually looks like in the frequency domain. This slide is very busy, but all I want to illustrate is what the time curves actually look like in the resting state. What we are essentially looking for is that specific voxels selected have curves similar to another area of the brain. Here I've simplified this concept to further illustrate what we're searching for in the resting state. Here we have a time curve for this green region of interest in the frontal lobe, and a second time curve for this area in the occipital lobe. When you compare this to a third region of interest in blue, what we see is an identical curve to the frontal region of interest. Therefore, we can assume that these two areas are somehow interrelated as their activity over time is similar. Therefore, we would classify these two areas as belonging to the same neuronal network. So just as with task-based functional MRI, there are many things to consider as far as potential limitations are concerned. I will not go deep into the technical factors as part of this presentation. However, I'd like to mention a few specific points. As you may imagine, this was initially met with some degree of skepticism. It's worth noting that these networks have been verified with both PET imaging and EEG, and have now been extensively studied with an overwhelming body of evidence to support their existence. There's also a large amount of literature showing the advantages of resting state functional MRI over task-based paradigms in the adult population. These include an improved signal-to-noise ratio, a minimization of experimental confounds such as unintended visual activation or auditory activation, secondary sensory association, attention networks, etc. These can be a potential source of confusion in these task-based studies. It is also well known to show high sensitivity to pathologic changes, perhaps even more reproducible than task-based studies. There is also a much higher test-pretest reliability. It has also been validated both during sleep and sedation, which makes it particularly powerful, in particular with neonates. There is also a better single-subject reproducibility. What I mean by this is that many functional MRI studies present group-level analysis. This means multiple subjects are averaged and concatenated into a single model, giving the picture typically shown in fMRI publications. For people who have done these studies, it's well known that the individual subjects rarely, if ever, look identical to the group-level data. This has been a tremendous barrier in the clinical applicability of functional MRI because of its poor single-subject predictability. For example, you may find at the group level that patients with X disease have 3 alterations in their functional study, but when analyzing each individual subject of that group, some of these patients may have none of those findings, whereas others may have any number from 1 to 3 of these individual findings. You can see the issue when trying to diagnose an individual patient when you apply the criteria from group-level analysis. Unfortunately, this problem is rampant in functional studies and rarely, if at all, discussed specifically. Additional benefits of resting state functional MRI include the ability to perform in any patient population because no interaction on the patient's part is required. Reliable data can also be obtained in as little as 5 minutes, which is a tremendous advantage over task-based studies. So as we encounter with DTI, the processing of resting state functional MRI is extremely complicated and highly variable. I show a quote from a paper by Dr. Jim Barkovich's group in which they said, "Connectomics is not a straightforward automatic step, but a model-building exercise entailing arbitrary assumptions and decisions which can have influential effects on the results of the analysis." What they mean by this is that there's really no gold standard on how we acquire and process this data, and many assumptions are made along the way. I would say one should be at least familiar with some of the more common methodologies of analyzing resting state functional MRI data. The first method is so-called seed-based approaches, which are similar to DTI, where you interrogate a specific area to determine its relationship with other areas in the brain. For example, if a region of interest was placed in the left motor cortex, we would expect to see all areas in the brain which have resting state communication with this area, such as the contralateral motor cortex through interhemispheric association fibers. This type of analysis is ideal for answering a direct question, but has limitations given that there are a priori decisions made about which areas to interrogate. A second methodology is independent component analysis, which is commonly abbreviated ICA. This is a computerized whole brain approach which maps all voxels in the brain to areas which have statistical similarity. This ideally will return data on all associated networks in the brain. The mathematics behind this are quite complicated and involve chaos theory mathematics. As such, the same data set processed 2 times may give slightly varying results. A third method for processing is so-called graph theory analysis. This is an interesting model because it integrates multiple data sets such as functional MRI, DTI, EEG, structural data, etc. into one unified connectivity model. I'll talk more about this in just a second. The last method I want to mention is multivariate pattern classification. This is a form of machine learning where the machine is presented with what you believe are normal patients and what you believe to be abnormal patients, and the machine essentially attempts to learn the differences between these 2 groups. After this, new subjects are presented to the machine, and it attempts to place the new subjects into one of these classifications. The machine will continue to learn as new subjects are presented or additional data is added to the model. So graph theory is a little bit easier to explain visually. We have here multiple nodes placed throughout the brain represented by green dots. As we begin to plug in functional MRI data, structural data, DTI data, etc., we start to build associations between these nodes, including the strength of the connection, the number of connections, which areas are connected to which, etc. The reason I believe this is an interesting model, although imperfect at this time, is because it integrates structural data with functional data. I believe this is ultimately where this advanced neuroimaging is headed because neither piece of data is necessarily conclusive in of itself. What I mean of this, again, is that the structural connections do not necessarily imply that two areas are functionally integrated, and a functional connection does not necessarily imply the expected structural connection is intact. If a particular white matter bundle was injured, the brain may have reorganized the functionality, giving a normal or near normal appearance on functional MRI, despite the fact that the structural data is abnormal. The other point is that DTI cannot give us information about second-order neurons, so connections we establish by DTI are only first-order synapses. Therefore, we cannot determine a functional connection between two areas in which there are not direct structural connections. So what are we looking for in the resting state functional MRI? Well, there are largely two opposing systems in the brain, the so-called default mode network, and then more attention or task-based systems such as somatosensory, visual, language, etc. The terms used to refer to these two systems include task-positive and task-negative networks. And what is meant by this is that the task-negative networks, i.e. the default mode network, appears to downregulate during cognitive tasks and vice versa. So what is this default mode network? Well, it's the major active network in the resting brain. No one's quite sure of its role, but it's been linked to the core processes of human cognition, including integration of cognitive and emotional processing, monitoring of the world around us, and memory. It also has tremendous overlap with the semantic language areas of the brain. Whatever its role, we're beginning to understand its importance in the human brain and the alteration in the pathologic brain. So I'd like to now briefly mention some of the resting state networks and their normal appearance. This data comes from an adult population in one of the Sentinel papers on resting state functional MRI. These are more common areas identified and do not look that different than you would expect from task-based paradigms. For instance, the primary visual cortex seen in A and B, which shows intense activation in the occipital lobes. In C, we see auditory and sensory association cortices with activity in the thalami and temporal lobes bilaterally. The network I draw specific attention to is in E. This is the default mode network. What we typically see is activation in the posterior cingulate cortex and precuneus, the inferior parietal lobules, the mesial frontal lobes, and more subtle activity can be seen in the hippocampi and in the cerebellum. These tend to be the more commonly appreciated areas on functional MRI as opposed to PET imaging. So why might we be interested in using resting state functional MRI and HIE? Well, there's a growing body of knowledge in adult brain injury showing the consequences of damage are dependent not only on the effects of the local damage, but also on the effect of the larger network pathway damage. Multiple studies have shown that abnormalities that occur in the cortical midline and the temporoparietal junction produce large, widely distributed changes in functional connectivity within and across hemispheres. In contrast, lesions affecting the primary sensoromotor and visual cortices tend to produce the expected local effects without significant change in global connectivity. These findings turn out to be tightly related to overall patient outcome. In a recent study by Park, they have shown acute compensatory changes in resting state networks in adult stroke patients, which was correlated with cognitive function recovery. The primary finding identified was a decrease in connectivity of the dorsolateral prefrontal cortex and the contralateral lesional hemisphere, which was a significant predictor of cognitive function recovery. Based on this growing body of evidence that functional changes have a strong prognostic value in adult stroke patients, we can assume similar findings can be seen in the neonatal population. Unfortunately, this data cannot be directly extrapolated to neonates due to significant differences in the neonatal and adult brains. There are some additional barriers to implementing functional MRI in neonates. As with all other imaging, it's markedly more difficult to define normal in this patient population. The bulk of resting state functional studies in neonates has been the investigation of normal development. Surprisingly, these studies have been fairly consistent, which is not often the case in functional MRI due to variances in acquisition, paradigms, and post-processing. The bulk of studies have shown that some resting state networks can be seen as early as 26 weeks. However, some activation patterns were not found in the most preterm neonates. All of the major resting state networks in the adult brain can be identified by term. However, they did have a variable appearance compared with their adult counterparts. Here is data from a paper published by Doria in 2010, which was really a landmark paper in characterizing the appearance of these resting state networks in the perinatal period. A few things to point out are the lack of significant change in the visual and the auditory networks from early preterm throughout the term group. This is not surprising, as one would expect these to be more well-defined networks in this patient population as opposed to more complex networks such as somatosensory, motor, attention, etc. When looking at the default mode network, what we see is a poorly recognized pattern in the early preterm group where there is significant mesial frontal activity, as well as this unusual activity in the operculum, which disappears and then reappears in the term equivalent neonate, but is not seen in the term control. As we move to term, we start to see a more adult-like and recognizable configuration of the default mode network. The other thing that we see throughout most of these networks is a generalized increase in interhemispheric connectivity. If we look particularly at the motor and somatosensory networks, we see that this unilateral activation evolves into more interhemispheric and bilateral connectivity. So these findings are similar to another major study by Lee, where they found that at a preterm age, connectivity with respect to any of the seeds was centered mostly around the seed region, and then by 2 or 4 years of age, these large regions of connectivity developed into more localized regions with increased global activity. You can see this in a visual representation here. And what we see is a movement from these large blobs that are centered around the seed area that evolve into more localized blobs with increased interhemispheric connectivity. So far, we've seen ICA and seed-based studies. Few graph theory studies have been done and show that as age progresses, we see an increase in global brain network efficiency and a decrease in local connectivity, i.e. short local connections progress to more long-range connections within the brain. These increases in global brain efficiency coincide with strengthening of longer-range association fibers during the first few years of life. So in summary, some resting state networks are present as early as 26 weeks. Most present by term, but they may differ from their adult counterparts. The early networks show higher levels of local connectivity, which progresses to more global efficiency and increased interhemispheric connections with age. Studies suggest there is a predictable rate of normal development, but there is significant heterogeneity in studies due to differing techniques. There are recent studies in adults which suggest a significant prognostic value in resting state functional MRI, particularly in ischemic injury. Extrapolation to neonates presents significant difficulties, however. More longitudinal investigations in neonates are needed to determine the exact role of resting state functional MRI in HIE. My opinion is to get used to it, that this is here to stay. This is really a novel way of seeing how the in vivo brain works. While it is fairly in its infancy at this point, further investigation and further studies will drastically improve both functional MRI and DTI. So where do we go from here? Well, we need more longitudinal data for starters. To better understand the prognostic value as well as the difference of abnormal and normal, we really need to further follow-up and longitudinal analysis in these patients. We also need improved algorithms for image processing and segmentation. These continue to evolve almost by the day, and unfortunately that results in a large heterogeneity of the way things are done, but hopefully as we begin to understand more, we will somewhat perfect these and move more towards a gold standard in processing. We also must work on understanding the difference in functional and structural connectivity. And I mentioned this point several times, and I feel pretty strongly about this because they both have limitations in functional and connectivity analysis, but when they are combined together in one model, they really do have a much more powerful role in predicting abnormalities. And going along with that, what we really also need is integration of these methods with producing a more comprehensible whole brain analysis. And unfortunately, the brain is so complex in its workings that oftentimes these studies are really hard to interpret, particularly when they're abnormal, what is going on. We also need further validation of our data versus clinical models. So thank you for tuning in, and if you have any questions, feel free to contact us here at the University of Florida. Thank you for tuning in.